everyone. Last but certainly not least, it's a pleasure to introduce Adam Sanderson. Adam's got a long history of working in medical technology, and he's been at Intuitive for over 10 years, where he's currently director of the UK and Ireland, and he's kindly going to talk to us about how Intuitive have contributed to robotic HPB surgery in the UK. Thank you, Adam.
Thank you very much. Great to see you all, and thank you, Jawad, for the kind invite to come and speak today. As per the introduction, Adam Sanderson, I'm Regional Director responsible for Intuitive in the UK and Ireland. I'm going to talk to you a little bit around how we've worked together and what we're doing now to try and contribute to the advancement of robotic HPB surgery in the UK and Ireland. A couple of words, actually, sorry. Forward one too many slides there. I would just like to acknowledge a lot of the content so far. I'm very aware that there are many people who've contributed and started on robotic pathways with Da Vinci, continue to invest in the technology, and I would just like to acknowledge that and say thank you for your continued support and obviously the value that you get from not just the technology but also the programs. I'm going to talk to three main things: challenges and how we can help. Improving our patient care in the UK and Ireland, how are we actually doing, where are we up to? And thirdly, a little bit around productivity. For those of you who may not be aware, the vision of Intuitive and what we really strive for day in, day out is all around producing a future where care is less invasive. People are able to get diagnosed more quickly, they're able to get back to what matters most to them more quickly. That's really the sort of the raison d'etre for the company. Take that to the NHS environment. We know that there are lots and lots of challenges facing the NHS, and we can't touch on all of these today, but a few may be ageing populations, waiting lists, productivity, sustainability, pressure on healthcare expenditures. I've just come from the HSJ meeting. We were lucky enough to have Sir Jim Mackey talking, and now in terms of the UK and Ireland landscape is one of those challenging times that we've been in for some time now. So we have many problems to solve, and we'll share with you a little bit around how we as an organisation can hope to help to address some of those things. Three main areas here are really around raising surgical capabilities to help standardise great outcomes. Thank you to all the speakers who've already been before me today. I think it's really evident if we're not helping to drive improved outcomes, there's really not much point starting the programs at all. So that's absolutely critical. Secondly, high quality, minimally invasive surgery. How do we make this more accessible for more patients through more surgeons more of the time? And thirdly, how can we help with the crucial challenge of gaining more and more efficiency with staffing and also healthcare costs? I'll share with you a little bit about how we approach this as an organisation. So we have essentially five main pillars, if you like, to our quintuple aim. So first one is around better outcomes. Can we help, or can we be part of that process to enable more surgeons to improve length of stay, reduce complication rates, reduce readmission rates? How do we also help to improve the patient experience, recovery, conversions, getting back to what it is that really matters most to them? How do we look after the care team during the process? How do we make it easier for them, working on things like ergonomics, OR efficiencies? And if we get these things right, time and time again now, and I've been with the organisation around about 12 years, clearly the organisation's been running for about 30, we've been shown by many hospitals in many healthcare systems that we can lower the total cost of care. The fifth pillar is really about improving patient access, and this is something we have by no means cracked, but it's something we're actively working on with the likes of yourselves day in, day out. A little bit of history before we start. So as I said before, we're in a fairly unique position in terms of robotics. So at Da Vinci and Intuitive, we've had about 30 years to be working on this, which is a reasonable amount of time. We've tried lots of different setups, lots of different prototypes, lots of different approaches. I think the point that I wanted to make here really is that we've always been really dedicated to solving problems and looking to address issues or perhaps opportunities within healthcare where we've looked at it as an organisation and thought, you know what, something could be done to improve this. We're an engineer-led company. Our corporate executive team are actually some of the first engineers who were kind of toiling away 30 years ago, trying to keep the lights on in a small workshop in the Bay Area. And they're the people effectively running the organisation today. So that's maintained true all the way to this time. And it's something that's kind of part of the DNA of the organisation. So essentially, we've not really brought out products unless we've known specific problems to try and address with them. This has brought us to a point now where we've got a portfolio of systems. So obviously the multi-port platform, we have single port, we've got we've moved away from, or as well as surgery, moved into diagnostics with things like the ION platform, diagnostics for the lung, and continue to commit a huge amount of money into research and development to keep progressing and to keep adding value to the likes of yourselves. The other thing, for those of you who may not be aware, but the other thing and the main focus that we've been looking at for the last 20, 30 years is, as alongside all the technological advances, is what do we build around that? And I suppose my one ask to everybody in this room is, if you have a program and you see anything on this slide that you're not taking advantage of, please go back, speak to your local Intuitive representatives, because it's there and it's part of what we're trying to provide. Systems, yeah, you can absolutely rely on a full range of advanced technology, full range of instruments, multiple platforms within the portfolio. But as well as that, learning, online education, technology training, academic training programs, all underpinned through servicing to keep things running, obviously, maintaining those 99% uptimes, and also ensuring that you're able to access meaningful, useful data to know, actually, are the programs delivering? Are they setting out and achieving what you invested in the first place for? So it brings us to this position now. We talked about the platforms, the advanced instrumentation, the full range of instruments for multi-specialities. We also have digital solutions alongside that to ensure that you're getting constant feedback as to how the programs are developing and how you personally as surgeons are evolving also. Where we're up to in the UK, around about 200 systems now, 1,000 plus surgeons trained to date, 100 plus proctors and hosts to date. We could go into the rest of the statistics, but it's been up and running for some time now, and we continue to evolve. I wanted to share this slide. It shows a little bit of the trajectory, really, of growth within general surgery, and it's something that I probably didn't necessarily think I'd be standing here today talking about if you'd asked me 5 or 6 years ago. But we're seeing huge amounts of growth, development, and adoption and value in general surgery now. I did expect to see that. What I didn't necessarily expect to see is the high minimally invasive surgery adoption within cholecystectomy. Now, overall numbers are fairly low compared to how many procedures are going out there, but these curves are absolutely climbing steeply. A couple of reasons for that, and I'm sure you've got your own views on this as well. Firstly, it's around training, productivity. How do we ensure that when we're introducing these programs within the NHS environment, we're not doing it at the cost of productivity and efficiency? So that's one thing. The other thing is, from the feedback from working with the surgeons, is around the increasing complexity because of how long people have potentially waited, meaning that the surgery is actually perhaps not as simple as we thought. There is more complexity, and there's more and more advantage of a platform where you can see better, move better, etc. So something to think about as we move through. Sorry, the clicker's just not working. But essentially, we've been working with the NHS since around about 2000. We know that the outcomes are improving. We know that a huge amount of open surgery has shifted to Da Vinci robotic surgery in that time. We also know that people have taken hugely successful laparoscopic practice and still improved on their results from moving. But we've still got a long way to go. talked about challenges in the NHS, and the theme of the talk was really around, like, what are we doing to contribute? Well, the best thing I wanted to talk about in the time that I had was actually probably how are we addressing the biggest challenge we have right now across the NHS, which is really around productivity and waiting lists. And I think HPB surgery is particularly relevant to this. So right now, we have about 7.5 million elective procedures on the waiting list nationally. 250,000 people have waited over a year for treatment. And this, amongst other things, as you probably know, prompted the Labour government to say, actually, what about these high intensity lists? How can we work on the backlog here? And here's 20 trusts within the UK where we actually need to focus on 4 high intensity lists, where they've got high levels of unemployment and essentially poor health. So hit lists and productivity has been something that many hospitals have led on, and we've helped to support and build out blueprints for people to be able to take this and scale. And many of them have been general surgery and HPB based. Increasing productivity, this is just some information that we have from our own databases. Essentially, it shows the number of hospitals by speciality who've been able to increase their productivity. So they're doing more procedures on a list with their Da Vinci program than they were able to do either open or laparoscopically. Multi-speciality, we're seeing it time and time again. The system, and I think the approach has shifted, certainly from when I began about 12 years ago. At that point, I think the Da Vinci system, largely based on prostatectomy, was really something that was looked at for these big, complex procedures that maybe couldn't be done minimally invasively any other way. And while that still remains absolutely a fact and a huge reason for why many people want to look at procedures on the Da Vinci system, there is also increasing recognition now that it's potentially, if done correctly, an efficient and a more productive way to actually operate. This is highlighted, and I know Mr. Van Boxel will be talking tomorrow, but just to give you a bit of a context and an example. So Heis Van Boxel, working at the QA hospital in Portsmouth, was actually able to move from 5 Da Vinci cholecystectomies on a list up to 8 through working on a hit list setup in the hospital. This meant that he could actually do 38 incremental procedures treated in 5 different hit lists over 12 months. They've actually found a way at Portsmouth where they like to incorporate this, and every month or so they're operating on hit lists and addressing their backlog as part of a solution. Other hospitals are doing it differently, and they're looking at, well, how do we take those best practice elements, bring that into daily, weekly working so that we can add 1 or 2 more cholecystectomies on a list, where perhaps we were doing 2 major procedures otherwise, but weren't necessarily doing anything with the extra time. So definitely more to come, I'm sure, from Mr. Van Boxel when he speaks to you tomorrow. But I will share with you his data on his findings for doing this. So on the charts you can see here in dark blue, Da Vinci hit lists. Sorry, I'm probably good. I'll move now towards the end of the talk so you can actually see the slides. Dark blue, you see Da Vinci hit list. Light blue, Da Vinci standard lists, so what happens day to day with Mr. Van Boxel. And then in the grey, you can see what was happening laparoscopically. So you can see the operative time reduces in the hit list, again, compared to what he was doing on a standard Da Vinci list and also laparoscopic. Conversions, complications, reoperations, nil across the board with the Da Vinci procedures. And then you look at day case rate, and he was achieving a higher day case rate on those hit lists that he was working on. So essentially what he's found was he's been able to be more productive, but it's not at the cost of any of the clinical outcomes. I thought it might be interesting just to share a little bit of what the setup looks like. So I'll stand back and let you see what's going on. So this is taken from Heis's own list. We just brought the patient in, setting up, 8:55. Patient comes in. Ready to deploy the robot for docking. And starting at around 9:10. So it's obviously well drilled, and it's been a contributor to part of the blueprints we talked to before. But if running those kind of lists or taking the best practice from those lists is something of interest, I'd be happy to share some information. I'm sure we can talk to it tomorrow as well. The other thing, in terms of productivity,
Adam, are you almost ready to wrap up your time?
Okay, yeah, no problem at all. Laparoscopic. So I would just conclude by saying that the other thing that we're able to do is work on staffing optimization, and many hospitals have also addressed the staffing challenges that the NHS are finding now by being able to reduce the number of people needed in any one particular theatre list and to be able to repurpose those people to use efficiently elsewhere. With that, I will just finally close off with our commitment to training. Happy to take any questions on that or speak in the break. And obviously to introduce the pillars of the academic pathway if anyone has interest in academic training programs for people from ST3 to ST8. And with that, I'll close due to time. Thank you.
Adam, thanks very much. Really interesting talk, and we're very thankful to the support we've had from Intuitive in our service. I just wanted to highlight one thing. We're all here to learn robotic HPB surgery or practice robotic HPB surgery, and that's had major implications for trainees. Patients senior trainees who would have been doing more straightforward Whipples on ampullary lesions are losing that ability as those patients are moving towards robotic approaches, and consultants are building their expertise. My worry with these hit lists are these are not a huge number of operations to be done that can be achieved in the week, and it is taking gallbladder surgery, which is a tenet of general surgery, away from the trainees, because these patients are clearly well selected if they're being done in half an hour. So I'm not sure it should be completely lauded from a trainee's perspective.
Managerial hat on, they are phenomenally expensive for what they achieve in terms of staffing, and we worked out that that actually hit lists to staff our hit list theatres does cost us more. We get more cases done, and that headline's great, but it costs us more at a practical level. And the other thing is, as Raj has already intimated in the Guildford approach to training and hit lists, I'm aware that a trainee sitting not a million miles away from me did 5 gallbladders in a standard list from 8:30 till 5:30 on her own once she was an established level 1 robotic surgeon. You don't need a hit list to get up to those sorts of numbers. You need good theatre productivity. Now, in fairness to Intuitive, they have a Genesis program which is very good and can increase your theatre productivity, and that's great. But let's not lose sight of the fact that there are other mechanisms that are not hit lists. And then the other thing I just wanted to say is all the speakers really touched on the difficulty of what in the UK are really good outcomes from UK HPB, and the difficulty when you transition to robots of proving that there's either advantage or disadvantage. So does the panel or do any of the speakers have a thought on what sort of outcomes we should be looking at, either to demonstrate real terms differences or demonstrate disadvantages, if there are any that we're not seeing in the objectives? And how do you keep robot programs going where if you do 5 robot Whipples and one of them has a bad outcome, that's 20%, and the UK outcomes for open are better than that? And that's a really difficult thing that I think as a robotic community we need to face.
Anyone on the floor want to answer that? Well, I think, as you said, Tim, it's difficult. There's a lot of critique of robot programs, especially during their learning curve. Most of that critique comes from colleagues, and being very transparent in your outcomes and providing honest data, just like Zahir did in his talk, and discussing the options in these forums and the outcomes is important. And at some point you need to get people like Jawad or Declan, who've got a huge, or Ryan, who've got a huge amount of experience. It's a friendly small community to come in and see what you're doing, or go and visit them to see that there are improvements. Yes.
Would it be all right if I responded just quickly? Thank you. So thank you for the feedback, and I appreciate the comments. I think just to come back on the point that with productivity, to be really, really clear, I'm not for a second saying that hit lists, and certainly Da Vinci hit lists, are the panacea to all of the problems of productivity for the UK right now. I think the point I was trying to touch on was that hit lists in general have been seen as a way to tackle the backlog, rightly or wrongly, right? It's been recognised by the government. And what we've seen, not necessarily by implementing regular hit lists, but by working with hospitals to do that, like what I should say is they've seen certain best practices that many hospitals have been able to incorporate into their day-to-day working. So I fully accept, absolutely, if you have a productive list, I think as you're talking to anyway, you don't necessarily need them. But does everybody nationally have hugely productive lists in every single area? And I think the collective answer potentially no there, can make some improvements. And then to the other point on day case, I completely agree with you. Again, we're working with hospitals to try and shift more and more high volume, low complexity procedures to day case, and there's increasing evidence on that as well. So thank you for the comments, and I don't disagree at all. I think it's more around principles, and it would be a costly way to roll out a highly productive list across the country. Thank you.